Well, good morning, good afternoon, everyone. Welcome to today's webinar. Before I introduce our speaker, a brief house cleaning item. Some accrediting bodies allow non-sanctioned education hours. So if you'd like a certificate of participation for today's event, please email sales@bestnotes.com. That's sales@bestnotes.com. Now, it's my pleasure to introduce Dr. Michael Miller, who is a board-certified addiction psychiatrist, a distinguished fellow of the American Society of Addiction Medicine, and a distinguished life fellow of the American Psychiatric Association. He has graciously agreed to talk about advanced harm reduction strategies with us today. If you have any questions for Dr. Miller, please enter them in the Q&A section of Zoom, and we'll do our best to get to them at the end of the presentation. Dr. Miller, thank you so much for your time. Please take it away.
Well, thanks, John. Can everybody see me? John, give me a verbal because I'm looking at the slides only.
Gotcha. Yep.
Okay, so and can you see the first slide? You can see both, and I'm ready
Looks
to
great.
roll.
Yep. Ready to
Okay.
go.
Well, John came up with the title, and how advanced is this? Well, there are some new strategies because the world keeps evolving. Would I call them advanced or just new? And then there's broadening of the concept, which I actually have some issues with, but we'll certainly talk about that. And if you want to call all of that advanced, that's fine, but there'll be some basic stuff of harm reduction here too. So we're going to talk about harm reduction and how it fits into what you do every day. And I didn't even make a title slide. So we just jump right in. But I am indeed an addiction psychiatrist, but I'm also a board certified addiction medicine physician and was part of the group that actually helped create the board certification process for addiction medicine around 2017. And I've been doing this work for 41 years, most of it in Wisconsin, now out in California. But harm reduction. I will give you some resources and tell you where I stole some of my slides and borrowed some of my concepts. But the Harm Reduction Coalition has their website, which is interesting, and that's one of the links you're going to see me talking about. But this is their kind of intro. A set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use without necessarily reducing or eliminating drug use itself. It's what can you do without eliminating drug use that's still extremely helpful, maybe life-saving for patients. But as it says in the next sentence, it's also a movement for social justice, which I'm not sure that that's. Why don't we just call social justice social justice? Why do you call it harm reduction? And it is interesting how it's morphed into something that's not really practical strategies aimed at reducing the negative consequences associated with drug use. So we're going to talk about this concept of blurring the meaning of harm reduction. So let's say you work in a residential addiction program or in an IOP and somebody's using, so do you discharge them? I mean, we've seen that. You kick somebody out for using, which is kind of interesting. They're sick, so you eject them from treatment. I mean, if somebody has congestive heart failure, they eat a whole bag of Lay's or pork rinds, they take a whole big load of salt and their ankles balloon up with edema. Do you discharge them for what they did? If somebody already has, emphysema and smokes, do you discharge them? So, in medicine, we don't penalize people for being sick. We welcome them when they're sick and we take care of them when they're sick. And addiction, for some reason, thought that we had to insist on the endpoint, that people had to be at abstinence, and if they ever lost it along the way, you would show them the door. So that's kind of bizarre. But what do you do if somebody's using? And harm reduction is an approach to improve the health of that person who is still using and to improve the health of the public. And it is aimed at two different things. It's not just helping this person, but there's benefits for people all around. But again, it's things to reduce harm when somebody is using. It's not to reduce the harm of the war on drugs on them. So we can partner with patients and become very collaborative. We use non-judgmental and non-coercive methods. We assist patients in reducing harms. We support their goals, being very patient-centered, and we can increase their chances of staying engaged. Now, what I teach my medical students and residents and fellows is what's the most important outcome from any addiction outpatient encounter. And I think all of you know the most important outcome of any outpatient encounter is that there will be another one. Because if they don't see you, you can't help them. There's no way that you can bring any of your bag of tricks, your talents, your skills, your experience to bear to assist them if you're not involved with them. And whether you're involved with them or not depends on their choice to show up. And so there are a lot of concepts in harm reduction that help with keeping the patient engaged so you get a chance to see them more. And showing them the door is not a way to stay engaged, it ends the engagement. And it's kind of a weird way to think. So we do want people to think about the concept of engagement. So in its very simplest form, it says if all you're offering is abstinence-based treatment, that means it's people that are in the action phase at their motivational level. They're not just contemplating or preparing. If all you're working with is people in the action phase of change, you're going to miss everybody who's not ready for full action. You'll miss those who still choose to use. And this is some people or a lot of people. So, what else can you do? Well, the earliest approaches, just from IV drug use, the patients themselves figured it out. If you're passing around a syringe, you give it to the guy who's yellow last. Um, Interesting idea. We don't want to pick up hepatitis from sharing needles. So we're not going to use the needle or the syringe after the guy who's already got jaundice from their liver disease uses. That's harm reduction. We're not going to get sick from the next guy. Um, I met with Steve Heilig this weekend, and he was talking about some of the original things back in the 60s they taught people, the teach it and bleach it, the whole idea of cleaning up your injection equipment so that it was all clean needles so you wouldn't transmit infectious diseases. Back then it was called non-A, non-B hepatitis. Um, Obviously, if you're not going to abstain from sex, you use safe sex practices to prevent harms that can come through sex, sexually transmitted diseases. I mean, some of these concepts are super simple, and I think it helps sometimes to think in terms of simplicity. Um, so, how do you reduce harms from drinking? Well, drink when you're sitting on a stool, but not when you're sitting behind the wheel. That'll reduce harms. Um, if you're drinking, what can you do to not get over intoxicated? Dilute it and eat so that you slow gastric absorption so it stays in your stomach and doesn't get to your intestines quite as quick and therefore to your brain. So, I mean, that's a way to reduce harm from drinking, is to affect how much gets to your brain. If you do drink, don't take sedatives on top of it. If you take sedatives, don't drink on top of it. And we all learned this through Marilyn Monroe's death about 60 something years ago. Back in the pre-benzo days, when the sedatives were all barbs and the things that were called non-barbiturate sedative hypnotics, I mean, they were very, very sedating and affected respiration, but you mix alcohol and it could be fatal. So, people don't like the idea of condoms with oral sex, but, do you want to swallow infectious particles or not? Um, and uh, and then I had those other two comments from Steve. I got both those ideas from him. So, there's basic things to do to reduce harms, but I like this slide because it says that harm reduction is something that's part of life. And what they've put in here is addiction harm reduction techniques interposed with basic things like bicycle helmets, seat belts, designated drivers, life jackets, bulletproof vests, parachutes, sunscreen. It's all harm reduction. It's all harm reduction, as is overdose reversal with Narcan, as is personal protective equipment for, aerially transmitted viral diseases, as is safe syringe disposal, as is, different stuff. So it fits into stuff that's not controversial. Harm reduction has gotten to be controversial, but it's silly for it to be controversial because it's just what we should all do. First, do no harm. So again, it's practical strategies, but it also can be this social movement. And so this is one source of information. And they talk a lot about the social movement. I'm going to talk about it. And I have nothing wrong with it. I think the social movement is great, but is that really harm reduction? Um, Now, I borrowed slides from a couple of colleagues. I've been a part of a project for 5 years or so, um, run by a company called JSI, which stands for John Snow Incorporated, that's gets a lot of government contracts. This is a big HRSA contract to enhance the quality of addiction treatment in rural northern New England. Um, and so I'm part of that ECHO project, and Project ECHO is copyrighted by the University of New Mexico as a mechanism of continuing education to practitioners in remote areas using Zoom and a very specific technology of designing a 1 hour intensive experience that is extremely educational. So it's been a lot of fun. The first one was called Treating Addiction Together, and it was back in 2019. And Anne is a wonderful addiction nurse, and these two colleagues gave this talk, and I've stole some slides from them. Also, more recently this year, some of Ryan's slides, and we'll introduce you to Ryan Fowler, who works at a syringe program in very rural northern New Hampshire. And he gave a talk to the group, and some of his slides are excellent. So I borrowed those. So again, what are the goals? It's to help individuals, but also other people. When you use harm reduction techniques, you can help the individual, but you can help their social network, people that interact with them. But again, it can be a broader thing. And again, people love dealing with these social things because it's the right thing to do. It's good humanistic interactions. Get rid of homophobia and sexism and social isolation, and use trauma-informed care, and have respect the roles of diversity, inclusion, and all sorts of stuff. It's patient-centered, it's patient empowerment, it's patient respect. It's all sorts of things that you want to do with anybody. Uh, Again, I'm not quite sure why it needs to be appropriated under the label of harm reduction. It's just these are good things to do. So the HIV Resource Center, I guess that's what it's called. It's not just a syringe exchange program. It's an HIV Resource Center that helps reduce transmission of HIV in rural areas. But that's where Ryan works. So again, I want to thank him, and he's given permission for me to use any of his stuff. And but I want to give attribution to him and to the ECHO project that we're doing. So you're looking for any positive change. It's person-driven. It's not coercive treatment. It's not punitive. And I guess it's a reaction to back in the old days when addiction counseling was very confrontational and did seem to be punitive. And still, a lot of people use drug testing in a punitive way. It's as a gotcha mechanism, which is it never should be and never should have been. So we want to be respectful of people who use drugs, and not be punitive, and but also let them be in charge of their own journey. And as it says, stop moralizing and having these over moralized approaches dictate what's done. Do what the evidence says, and the evidence says do some of the things we're going to talk about today, like even safe injection sites. And recognizing that some drugs are inherently more toxic than others, and route of administration matters a whole lot. So again, if people are using, how can you make it less harmful? That's as simple as I can put it. And at the end, I'm going to share some of my editorial comments about this whole deal. why even put harm reduction into its own category? Why not say that we do harm reduction with every patient every day because it's the right thing to do, and it is, and you can integrate it into what you do. So this is a really simple slide, and it says you cannot use drugs. You can use drugs in or alcohol in moderation. You can use them really, really heavily. Um, Heavier use is associated with greater risk of harms, health harms, and other harms. Decreased risk comes from decreased use. Uh, More symptoms with more use, less symptoms with better control over use. And this says any step is a good step if it's in the right direction. So anything towards abstinence, but people don't have to be at abstinence for you to be helpful to them. Helping them get toward abstinence is what you're attempting to do, but anything is better. Now, the thing is that moderation management actually is not an effective long-term strategy for addiction because impairment of control is inherent and people will lose control unpredictably when they least expect it and all that kind of stuff. Um, so for a person with addiction, you don't teach moderation management, but you can teach risk mitigation. And that's really what harm reduction is about, is risk mitigation if they're not yet at the point of embracing abstinence as their goal. Um, so one of the basic parts of harm reduction is reducing infectious disease risk, and the AIDS epidemic got everybody thinking about this, that, how can we reduce AIDS transmission? And all the safe sex practices is one thing, but more transmission is through drug use than through sexual contact. And so what do we in the drug use world do to improve the HIV status in our communities? And one is, if you insist on using, maybe use a route of administration that's less risky for transmission. And if you're going to inject, clean your injection equipment with bleach or whatever, or just get clean injection equipment. So whatever you're using to inject, you're not changing the drug necessarily, but you're changing the way it's delivered, and that can reduce infectious disease risk. And again, for making life better for the general public, let's have safe disposal sites for needles and put red boxes everywhere so that needles and syringes aren't hanging around on sidewalks in front of daycare centers, et cetera. So again, basic stuff. Um, so, some of the things that you can do, and this is kind of an overview of the whole talk. You can have information you provide to people on safe drug use practices. You can teach them things like never use alone. Um, uh, Teach them to always have Narcan nearby. And it's best to have Narcan nearby with somebody else so you're not alone, so they could administer it to you. And then the test strips for fentanyl and xylazine are some of the newest things. And again, is that advanced harm reduction, or is that just newest iteration of harm reduction? So that you can know that what you're using isn't contaminated with something that's more lethal than the euphoriant that you're seeking to use. Now, it's important to not slam harm reduction as being some misguided liberal conspiracy. It's not completely laissez-faire of whatever happens, happens. It's not anything goes. Um, it's not just meeting people where they are, it's helping them get to somewhere else. So it's not just, okay, you're not ready for all of the healthy things you could be doing, but let's use this opportunity for engagement with you to move things forward. Um, it's not enabling, it's not helping them to get use again, it's not endorsing drug use, it's not endorsement of policy change, including legalization. It's reducing harm. Let's keep it at what it is. It's reducing harm. And who can be against reducing harm? Why did I do that? What am I doing? There we go. So again, two general categories are um, needle programs and overdose reversal. So you can, it began with needle exchange. Then we realized that you need to have syringe exchange as well. And now it's moved toward overdose prevention centers, which is sort of the newest name for safe injection sites. Is that enabling? The evidence is very clear about safe injection sites being positive. We're going to drill down to that in just a second. Many of you may bristle at the idea of safe injection sites, but the data is just overwhelmingly clear, which is why an organization considered conservative like the American Medical Association has all sorts of policies supporting safe injection sites now, because the public health data is very clear. Overdose reversal with naloxone, Narcan, that's one thing. One thing is to have it. It's been available in hospital settings, emergency departments, intensive care units for years. But how do we get it out to where the actual overdose happens and where it can be effective early as opposed to later? And so one policy change was to say that you could write a standing order and that pharmacies could take this prescription drug and the pharmacist could dispense it to anybody who asked for it. Make it even easier, you take away its status as a prescription drug and just make it over the counter. Not every state in the union has over the counter naloxone, but many of them do. And where it's over the counter, again, we're trying to bring it to the people. Why would they have to go to a pharmacy to get it? Let's make it super easy for them to get it. And there's public health vending machines that, sell condoms, but also, have naloxone in them. So, and then obviously there's free naloxone dispensing through grants, through public health monies that go through public health departments. So we can get naloxone to people free through public health departments. In the VA, every person with addiction, every person with addiction gets prescribed naloxone, even people alcoholic, because they're around people who may overdose, even if they're not using drugs themselves. Naloxone is in everybody's pocket. Purse or briefcase may be the future, that you wouldn't go anywhere. I mean, everybody carries it. So that's a good practice, is to have it available, because you never know when you're going to run across somebody in a McDonald's bathroom that needs it. And maybe that McDonald's isn't supplied with naloxone next to their defibrillators, like is happening in some places, is they're being put next to defibrillators in public places. So naloxone is a wonderful thing, but there are issues with how somebody feels after they've been reversed, and there's a slide on that. But again, getting it out to where people may use it, educating people about it, educating family members about it. So again, if people are going to use drugs, and why don't we presume they are? Let's not presume that the entire culture is going to stop using drugs and be totally abstinent. So given that drug use is happening, how can we make it less harmful? Well, we can provide overdose reversal processes. Okay, so let's drill down on syringe safety. Needle and syringe exchange reduces HIV and hepatitis transmission. The thing that's really interesting is that, these services are a way of engagement. And so you talk to people about treatment. So these are people that didn't ask for treatment, but you have a mechanism that connects with them, builds up their trust. People are 3 times more likely to stop using drugs and 5 times more likely to actually enter treatment if they come to a syringe exchange program than if they don't at all and just get their syringes from other drug users in the community. They get dirty use syringes from people and needles. They're just staying out there using, they're not connecting with anybody that's health oriented. But if they come to a syringe exchange program, it greatly increases their chance of actually getting into treatment. And also reduces discarded needles in the community when they turn in their dirty stuff and pick up free new stuff. And it does not increase crime. So, the thing that kept these ideas from getting out there was, oh no, you're promoting drug use, you're enabling drug use, you're increasing drug use, you're increasing crime rates by people needing to get money to buy drugs. But that's scare tactics. The actual data is it doesn't make people use more drugs, and it doesn't increase crime. Okay, so again, if you have a syringe access system, you can do crisis intervention when needed. You can provide wound care when needed. You can do hepatitis C virus and human immunodeficiency virus testing and TB testing. So you can do public health. Again, it's it's a it's a bug light to get somebody to show up. It attracts people to the site. Now, the site may be a fixed site. The site may be a mobile van. Again, make it easier for people to contact you. But people, when they access the syringe access program, they're in contact with a trained professional who can do infectious disease testing, can provide Narcan education, can provide Narcan supplies, can get people enrolled in Medicaid. And if people are regulars, then there's actual care coordination that happens right there in the syringe exchange location. So it's a way to take people who are out there unengaged, who aren't ready for addiction treatment, but it's an intermediate step to engage them, and the results are that the referrals to formal treatment go up. So there we go. And syringe safety programs are endorsed by American Academy of Family Physicians, AMA, Bar Association, Public Health, Red Cross. The Drug Czar's office is the last one, World Health Organization. The reason all these organizations endorse it is because the evidence is so behind it that it works. Overdose prevention, again, don't use alone. Stagger your use so that you're using at different times, so that not everybody in the room is, using drugs by the nasal route or an injection route at the same time. Have some people awake and some people using, and make sure there's like a designated somebody off to the side. Don't use alone is such a simple concept, but so life-saving. So again, it's not moralizing and saying never use, or it's not saying you're a sinner if you use. It's saying if you're going to use drugs, don't use alone. And use a tester amount to make sure it's not like it's far more potent than you thought when you bought it. Go slow. Wait until you feel like you're in control. Don't mix downers with opioids. So these are the kind of messages. They can be offered by all sorts of people. They can be offered by, outreach workers. They can be offered by, child protection workers. They can be offered by, anybody. They can be offered by addiction counselors. They can be offered by recovery support specialists. They can be offered by anybody. But these, if you're doing abstinence-based treatment, great. But while you're there, you can tell people, should you use, I just want to give you some tips. Use a tester amount, go slow, and don't ever use alone. And they go, why are you telling me these things? Well, because I want you to be alive. I don't want an accident to happen. So this is accident prevention. One concept is you're more likely to have an overdose if you have systemic illness. So don't use when you're sick. Hydration is a great way to dilute anything. And so that's good. Change your route. Smoking is an extremely effective way to deliver drugs to your brain, and it doesn't involve the risks of injection as far as disease transmission. You can transmit diseases by snorting. You can, if you share straws, uh, viral diseases can be transmitted via sharing straws. But I don't know if you can transmit viruses like hepatitis C by putting your lips on a hookah with somebody else. But what are you putting in a hookah? That's usually going to be cannabis or tobacco. It's not going to be opioids. Of course, it could be opioids. Um, Most people don't use hookahs for opioids. Um, Again, testing for the presence of even more harmful things can be done now with test strips for fentanyl and xylazine that are passed out in some communities. Um, Carry the naloxone with you and know the signs of overdose. Okay. Uh, Now I got some extra slides here that I found on other people's slideshows that are pretty cool. So here's some slides on, we don't just have to talk about opioids and sedatives. What about speed? Um, the harm from speed is aggression, violence, psychosis, and stroke and heart disease from hyperdynamic cardiovascular system. So we all need a break sometimes. So spread it out. Try not to use all available supplies. Try to moderate your dose and um, allow your body to recover and get some sleep. Um, it's hard to do. And with addiction, one of the features for a lot of people, their addiction is consuming all supplies. So telling them not to consume all available supplies, they just can't do that. That's not part of their deal. But for some people, try to apply some parameters. Uh, so just like some alcoholics control how much they consume by um, buying smaller bottles or buying smaller proof or switching from high proof to low proof or whatever. Um, if you're going to consume all available supplies, you don't have the biggest supply. Um, don't buy 3 days worth because you may find yourself using 3 days worth. And for alcohol, that can knock you out. And for stimulants, it can lead to an overdose. And people do die from stimulant overdose from cardiovascular death. So um, again, stay hydrated, take breaks, um, take holidays, um, and again, avoid mixing. So um, some of these general bits of advice carry over from agent to agent. Now, this is interesting. When you do give Narcan to somebody who's had an opioid overdose, it's tough. They can come out, they can get awake in a state of acute withdrawal, which involves dopamine withdrawal, which involves lots of dysphoria. They can be extremely uncomfortable and they can be irritable. And so, if you're giving Narcan to somebody, what's going to happen when they come out of it? Um, so, tell them who you are and tell them that you gave them Narcan because it looked to you like they were overdosed. You show basic human concern and ask them if they're okay, and you get uh, gawkers away from the scene. And if they say, I'm just going to leave now, you don't hold them back and use non-judgmental support. Um, and just realize that uh, the person waking up from a reversal of an opioid overdose can be very, very, very dysphoric because their dopamine levels are very low. So, just another thing to think about. I guess those slides were out of order. Probably should have put that slide somewhere else. Back to the meth topic. Sample it before you slam it. Do a small test dose. Get some sense of potency. Make sure you're not going to be overdosing by you've got some higher potency stuff than you thought, and then using it all. Just give it a little taste first. Um, um, and Again, this is obviously one of Ryan's slides from northern New Hampshire. Fentanyl has contaminated the entire drug supply of everything. It's in, as I believe it's in counterfeit Xanax tablets from pill presses. It's in stimulant supplies, it's in sedative supplies, it's in all supplies, it's everywhere. So fentanyl test strips are a good thing to kind of see, well, what did I buy here before you use? Um, so magnesium can help with some of the muscle activity that happens with speed. Um, so interesting idea. Skin popping is it's a subcutaneous injection, just like you give a TB skin test. It goes in, it's a make a little bleb, and skin popping is used for opioids. So it's not into your vein or to your muscle, but it's into your subcutaneous space, and it's a drug delivery method. But skin popping with stimulants can be very bad, and obviously, skin popping with xylazine is very, very bad. Um, and then ideas about changing the cotton filter. I mean, all sorts of things just to it reduces the chance that a virus will come in through the drug you're trying to use and you're getting stuff you didn't intend to use. So these are actually very compassionate things you can teach people about how to make drug use less dangerous, and that's what harm reduction is: making drug use less dangerous. Um, so again, meet them where they are. Um, don't expect them to be rational all the time. Don't expect them to be consistent with follow through all the time. Don't expect them to be abstinent from the start. Um, um, just accept where they're at, and they're on their journey, but you can help move them down that stairway on that previous slide. Um, Now, this is, I don't call this harm reduction, I'll call this patient-centered care. And even the title says recovery-oriented systems of care. So this is a movement to develop, recovery-oriented systems of care where you ask people what they need rather than telling them what they need. You help them define their wants rather than you imposing your wants on them. You ask them to envision their future and then what can be done to increase their chances of getting to the future that they envision for themselves. Um, you don't give them a curriculum, you ask them what they want, and you don't consider them done if they walk out. You welcome them at any time. And this is patient-centered care, recovery-oriented system of care. It's gotten attached to harm reduction, but this isn't harm reduction. This is just recovery-oriented system of care. Um, Again, hearing them out, getting their viewpoint, uh, letting it be their world that they're sharing with you rather than you're trying to cram your world down their throat. And recognizing that behavior serves a purpose, and even drug use behavior is they're intending it to do something, and it may not be just to get high, it may be other things. And understanding what drives them to use is an important issue. So understand them, be caring, respectful, take your time, don't be rushed, uh, respect their coping mechanisms, their assumptions, be a good listener first. Isn't this how to be a good clinician? So, I mean, it really is kind of interesting that harm reduction thinks they're teaching people to not be horrible human beings when they're an addiction professional. Well, nobody should be a horrible human being when they're an addiction professional. You shouldn't yell at patients. You shouldn't cram treatment plans down people's throats. You shouldn't project your values onto them. Uh, you shouldn't should them. And so, and again, it gets wrapped into harm reduction some kind of way. But these aren't bad slides to share because all of us need to be reminded that being consistent and reliable and having clear limits, but not sadistic about it, and being willing to negotiate and compromise with people and affirm any progress. Uh, these are good things to do. And the other thing is your own self-care, getting good supervision, getting good emotional support, because this is hard work and it can be emotionally taxing. And so you want them to engage with you, but you need to engage with them and you need to be available to engage with them. And to do that, you have to be from a healthy vantage point yourself. So that's why self-care is important. Uh, Al-Anon is super helpful to help you have realistic expectations and realize that there's the limits to things you can control, and you just stay on your side of the street and not be on somebody else's side of the street. And the basic concepts of Al-Anon of living where you can, changing the things you can control, accepting the things you can't. The Serenity Prayer is helpful dealing with anybody with addiction because, again, you can do your best and be respectful, but you're not responsible for the outcome. You're not responsible for the outcome. And Al-Anon can help with that, or therapy or whatever self-care you need. And you're not supposed to work harder than them or be their rescuer, or get caught up in their own drama. You stay consistent, you stay calm. Just be calm and be respectful and be accepting. Um, so it's interesting how basic concepts of motivational interviewing are getting incorporated into talks on harm reduction. And those of you that know, motivation enhancement therapy, this basic issue of expressing empathy and developing discrepancy and all the basic principles. But is motivational interviewing harm reduction or just a good, healthy modality of interacting with people and rolling with resistance instead of trying to be confrontational? So just maybe just be aware of what's happening in the harm reduction area, that it's becoming this broader thing, talking about things like motivational interviewing, accepting people where they are, and improving social justice. So this, I think, is off topic, but a lot of people talk about harm reduction say that it's on topic. Again, open-ended questions, affirming, active listening, reflective listening, summarizing what you've heard. It's a way of interacting with people that, again, is not confrontational therapy, but nobody should be doing confrontational therapy anymore. I mean, yelling at somebody never is acceptable, and it doesn't get them to come back, and you want them to come back. Why do you want a success rate of 90% in a program that has a 90% dropout rate? Everybody's gone, people left, or, that's crazy. You want to reach the most people, and you do that by not driving them away. So here's the basic slides from Ryan. Some of this we'll take this from the top. So it's again, practical strategies to reduce the negative consequences when people are still using, or sometimes the slide says they made the choice to use. If people haven't chosen abstinence and they said, I'm still going to use, I just don't want to use as often, or don't want to have as many problems, or, reducing use and obviously using more safely is important. So again, safe drug using practices. Thinking about why people use drugs. Don't just have them tell you the negatives they've experienced, have them tell you the positives they've experienced, so that you can understand their decisional balance. And so you connect with them and realize that sometimes they're using drugs to connect with others in their social network. Some people use it to just to tune out and escape, but other people use it to, drugs can be a social lubricant just like alcohol can be. Maybe they're just trying to feel normal. Basically, drugs do two things. Drugs or alcohol do things. They can produce reward or they can produce relief. And in general, most people begin using because they want the buzz, they want the reward. And over time, with the brain changes, everybody ends up using it for relief because everybody's self-medicating their own dopamine withdrawal. that's induced by their drug use from the dopamine depletion they get, whether that's opioids or sedatives or stimulants or alcohol or what have you. So, but people use for different reasons. They use for reward, they use for relief, and drugs can provide both. Some people just use because they're stuck in the trap of addiction. They use compulsively and they can't stop. That's not really a choice anymore. Those people don't have the choice is because their amygdala is making their choices for them, and all the choices are happening at their midbrain, and their cortex doesn't get a chance to have much say so because they're driven to use compulsively by what neurologically happens in when addiction really gets set in. So um, if you're trying to engage with people, um, accepting that there are a lot of different reasons people use. So again, overdose reversal programs, syringe exchange programs, the drug testing to look for adulterants using point of care urine drug testing. Again, safer routes of administration, reduce infectious disease transmission, safe drug supplies. Um, again, most safe injection sites, people have to bring their own drug supplies in. There's not many that supply drugs. Maybe in Europe they do, but testing their supply to make sure it's what it says it is. Checking for fentanyl, checking for xylazine before they use it. And again, if it's a supervised injection site, if they overdose, you can either give them Narcan, and it's just a safe environment. And again, you can provide them education on other healthy things they can do, and eventually, these people are 5 times more likely to go get into treatment than if they hadn't been involved. It's an engagement process. Um, and I would say that things like criminal justice reform and housing first models are not really harm reduction. They're other things to just change the environment. Um, so, but one thing is to realize that people are going to get their basic needs met. Maybe first, maybe they see working in therapy or working in recovery as way up on the Maslow scale, whereas they're just trying to deal with food and shelter and clothing at first. And so helping make their life better gives them a chance to work on maybe some of the higher things like recovery work. Um, so compromise, negotiation, being constructive, saying yes as often as you can, saying no as rarely as you need to, um, and don't make ultimatums, don't coerce, and uh, this is just a great idea for any therapist anytime. You never take away people's coping mechanisms until others are in place. So again, some of this is just to be a good quality humanistic person, realize that harm reduction is a process, not an event. Um, really interesting slide here. Let's kind of a Hollywood squares or a quilt. Um, some of this thing of patient-centered care says there's two experts in the room. It's not just the therapist that has expertise. The patient actually knows themselves pretty well. See their pain, not the painkiller. Understand what's behind their decision to use. They're not using because they're stupid. They're using because they're desperate and that they have a lot of stuff in their lives and they've made a decision that using drugs will reduce their stuff or improve their coping or whatever. It's not healthy, but they're not necessarily seeing that. But if you lead with what a dumbass you are, then they're not going to come back. Um, so again, drug use is a health issue, not a crime. And you're not a bad person and you are not a sinner. You're somebody who's doing something that you think is in your best interest, but let's kind of examine that. And you're just trying to survive out there. And I understand that. So accept them as somebody who is just trying to survive out there. Now, again, I like these slides that Anne came up with in her college. Accept their ambivalence, respect where they are. And so when you're managing intoxication or withdrawal, um, again, provide a safe environment for that. Discuss all sorts of health issues, discuss the health harms that can happen, ask them if they've had experiences with skin infections or symptoms of heart failure from endocarditis or what have you. Um, give them information on alternatives, either alternative drug supplies, alternative drug routes, um, uh, and again, it's all about connecting them with you and connecting them with primary care and connecting them with mental health services, and just helping them not be so out there and not accessing anything. Um, you're providing them safety plans for suicide prevention and case management support, and again, you're not imposing your goals on them. You're asking them what their goals are, and you kind of respect their autonomy. You develop goals collaboratively uh, based on their readiness, and you always are trying to enhance their motivation to change. So you're bringing them along with you, or you're trying to. So any engagement is an opportunity for intervention, and that's what some of these things are. Is just make sure that the person isn't away from you, but has a chance to interact with you, a chance to engage, a chance to get um, comfortable with you, and eventually maybe work with a clinician on active treatment. Um, now, there's a lot less opioid prescribing now. Some of these slides are old, but keeping the dose low, co-prescribing naloxone, educating the family members. I mentioned that before. Don't mix benzos with opioids. Don't mix alcohol. These are all educational things that can reduce harm if people are using prescription opioids. This was an interesting thing at the ASAM Common Threads course. I was on the planning committee for 10 years for that one. And this particular physician gave this talk that had these slides that I thought were pretty cool. Again, individualizing care, respecting rights, acknowledge the spectrum, meeting people where they are, be non-judgmental. These approaches are all just good principles of good addiction care. So these are my editorial comments to kind of bring us to the home stretch. What's the problem with harm reduction? It's creating a false dichotomy saying it's treatment or harm reduction. And that was my talk of 20 years ago. I couldn't find those slides, but I was preaching this a long time ago. Why do you have to say it's either or? Why don't you do harm reduction every day with everything you do? That's, I think, the best way to do it. Who wouldn't want to reduce harms? It should be treatment, recovery, and harm reduction. And it should be practiced by every professional all the time, reducing harms. It gives you a chance to engage in a non-judgmental, non-coercive way, and then assess their harms and help them understand what's harmful and how they might reduce it. And again, instructions about how to inject and changing your cotton filters on your works, and providing them with safe injection equipment and Narcan and test strips and all sorts of stuff. Getting them engaged with health screening for general medical, infectious disease, mental health screening, and we ask them their goals. So this is good stuff. Why wouldn't you want to be patient-centered and let their goals be part of what you're doing? That's the way to win friends and influence people, not by telling them what they need to do. So I think there's a problem when you expand the concept so much that it loses its meaning. It's a catch-all basket in which to place all sorts of things like unconditional positive regard, just being kind, motivational enhancement therapy, and social justice. I mean, should we have social justice? Sure. But do we have to call it harm reduction? Again, this is a slide that says harm reduction means respect, dignity, and compassion. And it's a social movement to liberate people and to have drug policy reform and decriminalization. Why? I mean, yes, all those things are great. But do you have to call them harm reduction? Um, um, so, I don't want it to lose its meaning. It means reducing the harms associated with drug use. It doesn't mean reducing the harms associated with misguided approaches to substance use in our culture. This is Mike Miller's take-home message. Harm reduction doesn't mean you reduce the harms that people suffer from the war on drugs, from misguided approaches, from punitive approaches, from a criminalization approach. Um, uh, that's policy change. Um, harm reduction should be reducing harms from drug use, not reducing the harms that poverty causes in the lives of people who use drugs. I just think that the concept can get too blurred. And again, Shatterproof, a fascinating organization that works to improve treatment outcomes and to help consumers have access to knowing where to get treatment that's evidence-based and provides medications instead of saying you can't take meds in my facility and all kind of stuff like that. So Shatterproof's a great organization, but even they say harm reduction, um, it's more than just harm reduction. It's meeting people where they are. Well, that's just patient-centered care. Treating people with kindness and respect, that's just, come on. Um, and so the principles of harm reduction that they list do get kind of blurry. Certainly, you don't have to have people agreeing to total abstinence to be helped by the things you're going to offer them. Respecting the rights of people, of course, you want to respect their rights. Commitment to evidence, there's evidence for syringe exchange and safe injection sites. And if you follow the evidence and not your preconceived notions, people will have access. Avoiding stigma. Well, everybody should avoid stigma. So I think the biggest misnomer is calling methadone treatment or even buprenorphine treatment harm reduction. That the only thing that's worth talking about is abstinence-based, and that somehow agonist treatment is not abstinence and isn't legitimate, and it's just harm reduction. That's nonsense. Pharmacotherapy of addiction is addiction treatment. It's not harm reduction. They're treatment. So that's a big problem. Another worst thing is policy decisions that fund harm reduction and defund traditional treatment. I'm concerned that a lot of harm reduction approaches say that the only thing we can do is keep people alive. We can't really help them recover. We just can't do it. The problem is just overwhelming. Our systems can't do it. Let's just keep them alive and give them the lowest common denominator, and don't even think about suggesting to them that recovery is possible. Recovery is possible. And I don't want to sell people short. And that's a concern I've got. Is I'm not being texted repeatedly by John. I'm being texted repeatedly by other people. So sorry. So the best thing about harm reduction is it is an opportunity for engagement, and this will get more people into recovery. That's the best thing about harm reduction, is it serves your needs. So it's not either or. It's a way to get people involved with the treatment and recovery that you are trained to offer them. So there we go, before the top of the hour. So let me.
Wonderful job, Dr. Miller. I'm sorry we don't have time for questions today, but if this was your first time hearing Dr. Miller, I sent a link in the chat that has a list of past webinars we've done with Dr. Miller, and they're all equally as good. Dr. Miller, thank you again for your time today, and thanks everyone for attending. We'll see you next time.
Yeah, before everybody goes, one time John said, well, let's just have a Q&A session. And we can do that. And this is a kind of provocative subject. And we talked about, do we take these and make them into two things? If John wants to do it, it's going to come from you guys, the customer base. What do you really want? Would you like to have time just to discuss the concepts that were out there today? And that's possible. So I really, you're all good people and you want to help the people. And I just say, don't put things into silos. Don't say that treatment's over here and harm reduction's over here. Why? Then put them in the same silo and do harm reduction every day with every patient. And don't consider it to be something that's unique, and certainly not something different than what you do. And so I'm all about synthesis. And so if you want to have more discussion about these terms, these concepts, just let the Best Notes know, and we can do our best to make that happen for you. Have a great day, everybody.
Well said. Thanks, Dr. Miller. Thanks, everyone. See you later.